All right, so this is the beginning of the material for test 3. I did post up all the other PowerPoints that are going to be included for the test, and then the prescription assignment I put on there as well. That's going to be due, I think, November 1, I believe. It's the Friday before the exam.
That's true.
That is true, yes. So if you have any questions, let me know about that. So starting off, or any questions to begin with before? So something you may experience prior to the test tomorrow, or no, Friday, right? May feel like you're having some chest pain, maybe some palpitations, you know, may feel like you're going through ACS, but you won't be, right? Just a grim sense of humor is not shared by all here. That's okay. Well, let's talk about acute coronary syndromes. You've covered this in cardio already, correct?
Yes.
I believe Professor Gerke talked about this. So I'm just going to hit on some of the medications we're going to be using for this. I'm not going to get super in-depth on the pathophys, mainly just focusing on where our medications come into play on this. When we're seeing acute coronary syndrome, what does that mean specifically? It's chest pain, which is evidence of ischemia leading to infarction, right? So we're limiting the amount of blood getting to the heart, thus we're going to lead to that tissue dying off if you don't reperfuse that pretty quickly there. And again, usually the degree of occlusion of these vessels and the degree of limited oxygen flow is usually what is going to delineate between, like, say, a non-STEMI and a STEMI. In terms of drug therapy, it's going to differ a little bit. However, we'll see how therapy has kind of changed over time in order to manage these patients here. But some of it is going to be pretty common, as we'll see, because a lot of times, you know, initially you may not even know what the patient's actually experiencing until you actually do what? You could cath them, but if you're having chest pain and it's not being relieved by things like nitroglycerin, like, what do you need to determine if it's an NSTEMI or a STEMI? Get your EKG right, which you guys don't know how to do now, correct?
Yes.
100%. So anyway, did any STEMIs notice yesterday? Just a few? Okay, that's good. Hopefully everyone's all right. Still count. All right, everyone's still here, so that's good. Anywho, so what's happening when we have these thrombi that are forming, the thrombus forming? You see here is a vessel that has a bit of a plaque forming. Now, where does that plaque come from? You know, LDL cholesterol and kind of just inflammation over time. You know, hopefully you have this nice fibrous cap, which is, you know, still limiting some blood flow and some oxygen flow, but again, this is a stable plaque here. What can happen, though, as we know, especially if you either have something like a balloon deployment or if it could just happen on its own, you can have a spontaneous sort of rupture there, right? And what does that normally kick off? You see the clotting cascade gets started up here, right? And then once that endothelium gets interrupted, remember we talked about this in the hematology section, right? We were talking about our platelets, how they get activated here. And this is exactly what you're going to find. You're going to find that things like von Willebrand's factor is going to be expressed on underneath that endothelium, and then you're going to platelet adhesion, further activation, and they all start to aggregate. And then what ends up kind of holding them all together in a nice clot? Fibrin, right? Fibrin is going to be really important to cause that nice kind of that spider web sort of cement holding that stuff all together there, right? And so have you guys heard the term fibrinolytics?
Yes.
Previously, right? What do those do?
Break down clots.
They break down the clots, right? Because they specifically are going to break down the fibrin that's holding all those platelets together. And so we'll talk about its use of those medications a little bit later here. And again, once you kind of have that further propagation, this is where it becomes much more occlusive. Obviously, flow is going to be very low, and that's where you get the ischemia and eventual infarction happening. So what do you think is going to be our kind of main goals to try to interrupt this process here? What are some things we can do? And from a pharmacologic standpoint, because certainly the best thing would be to be able to go to the cath lab, right, and just clear that all out, give them the old rotor treatment, right? Maybe put a stent in or something, but pharmacologically speaking, what can we do to interrupt this process? Yeah, so we can inhibit the platelets, which we know how to do already, right? What are some means to do that? Aspirin is a very good starting agent here. What else? Plavix, which or clopidogrel, what category does that fit into? ADP blockers, right? So we can see by blocking cyclooxygenase, blocking ADP, that's going to be some. What other things could we do? What other classifications of antiplatelet drugs do we have? Another big one. 2B3A inhibitors, remember, and that help to prevent fibrinogen from cross-linking the platelets. So we see a couple things we can do on that side. What about on the actual clotting cascade? Heparin could be used, right? What else? Or for maybe more for the long term, but you don't normally would see that necessarily from this case here, but certainly it's a thought. What other kind of quick-acting agents could we use? Low molecular heparins like Lovenox, which is the brand name for what? Noxaparin, very good, right? We have like direct thrombin inhibitors, all that sort of thing there. So anyway, so you can see we're gonna be working kind of on both sides of these of the equation here, right? Working on the platelets, working on clotting cascade in order to help prevent further propagation, and then hopefully to eventually start to dissolve some of those clots down, which can be helped along by the fibrinolytics, which will kind of be the new drugs we'll talk about today. Anyway, and again, you can see how this is a sort of a positive feedback loop, whereby further activation of platelets and the clotting factors, that then leads to further activation of more clotting factors and whatnot. And so obviously remember that factors 10 and 2 were really important for this cascade, because that was part of that common pathway that then fed back and then started to activate more of the intrinsic and extrinsic pathways there. So, and remember that a lot of the clotting factors are going to have effects on the platelets to further help with aggregation from that standpoint as well. Again, the pathophys here, so I'm not going to get too big into that. Remember that thrombin is going to be the kind of the final step, though, that's causing that fibrinogen to convert over to fibrin. So again, if we have medications that can maybe prevent the actions of thrombin, that can help to prevent that kind of final step of the pathway there, which would be good. But once we have fibrin already formed, how do we get rid of it? That's where the fibrinolytics are going to come into play. You guys know any specific fibrinolytics that we have? Or TPA, what does TPA stand for? Toilet paper accessories? Yeah. No. Tissue plasminogen activator, which activates what? Plasminogen to convert over to plasmin, and then what does that do? That breaks down the clot, right? So again, it's not the drug itself that is degrading the fibrin, but it's speeding up the process there, right? So we'll look to see how that actually gets integrated into the kind of the pathway here. Anyway, so what's our goals when we have patients who are presenting with acute coronary syndrome? Obviously, we want to reestablish coronary blood flow, relieve that chest pain, right? We know some medications are going to be helpful for that. We'll talk about in a few moments here. If we can, if they're not already in full-blown MI, we can hopefully prevent further progression to there. And then obviously it's the kind of secondary effects we're worried about, things like developing heart failure. Obviously, we'd like to prevent death if possible, generally speaking. Yes? Everyone with me? I hope so. Unless you're religious, don't like your patients, in which case then we like all of our patients, right? Anywho, so we have the kind of the common pharmacologic therapy here for both STEMIs and non-STEMIs here. These are going to be kind of common drugs you'll be giving to both patients anyway. So obviously the first thing you would want to take is aspirin, right? How much? I don't ask a lot on doses, but we mentioned that kind of for daily sort of prevention of acute coronary syndromes. This is really kind of move more towards secondary prevention. So if people already have cardiovascular disease, these would be patients who are going to be taking aspirin. How much do they take daily just for normal prevention? 81, right? So it's a baby dose, but we're using it for adult patients because why? It's an irreversible inhibitor, right? So that's enough to treat all the platelets we have circulating around at any given time. However, when they do have acute coronary syndrome like this, we're giving how much? Yeah, and so typically we'll just give them like 4 baby aspirin, tell them to chew it up, and then just swallow that. Why do we tell them that? Why chew it up? Yeah, trying to aid up the dispersion of the drugs that will absorb a little bit faster, so that way it gets into the system a little more quickly, because again, time is tissue, right? So again, the earlier you can reestablish flow, the earlier you can interrupt these processes, the better it's going to be for your patient here. Because remember what did I say about the when you're giving nitroglycerin, like when you call 911? Yeah, if you don't have relief after the first 5 minutes, you go ahead and call 911. Before we'd say, well, take 3 doses, and then if you don't have relief, then call them. Well, even that 10-15 minutes can make a difference in some patients. That's why we are trying to, kind of increasing or speeding up the process here and decreasing the amount of time it takes to reestablish that flow. Now, we have our aspirin there, so that's been shown to reduce mortality. That's all good. We have nitrates here as well. What are those going to be useful for? And try to dilate. Yeah, it's going to relieve the chest pain by doing what? Dilating the coronary vessels is going to allow for more blood flow, hopefully, which should help with the chest pain there. But again, if you have a big thrombus in the way, it doesn't matter how much you want to dilate that vessel, it's not really going to be able to reestablish that flow. So it actually doesn't have any mortality benefits. What were some side effects you'd worry about with nitroglycerin? So you can see headache, but they're having heart attacks. I'm not so worried about that. But more important to flow of blood is what? Hypotension is a big thing, right? So, and remember what drugs were contraindicated for mixture with nitrates. So sildenafil and your other medications for erectile dysfunction, right? Which again could have been a precipitant to having the chest pain in the first place, right? So these are things to consider. These are questions you need to ask. Hey, have you taken any medications for erectile dysfunction lately? Now, is it only male patients you'd have to ask about that? It's a good question. Yes, you think so? Not necessarily, right? So, and in fact, we give little girls over at Nemours sildenafil, tadalafil all the time. And that sounds kind of silly because you're like, well, I don't think they have erectile dysfunction. They have no erectile function whatsoever. However, what you do find that it actually has good effects to dilate some of the pulmonary vessels. So it's actually useful for pulmonary hypertension. So it can be still useful to ask your patients a question, even if it's a female. Ask them, hey, do you have a history of pulmonary hypertension, right? Maybe they could be taking one of these phosphodiesterase inhibitors that could be interacting there. So just something to think about. But hypotension is usually going to be the big thing we're worried about here for these patients. So sublingual nitro, probably not going to do it. But if they, if EMS arrives and they start up an IV drip of nitroglycerin, that's where it's going to be more concerning, right? That's where you're going to be wanting to watch the pressure there. So have that. Then next we're going to have beta blockers. Beta blockers do have proven effects on mortality. Right, so this is going to be a good medication to get started up pretty early on. Now, who would be contraindicated from getting a beta blocker? So asthmatic patients, which ones would they be precluded from getting? Non-selective, right? So which kind of selective ones could we give? Metoprolol is a good one. Atenolol is a good one. Esmolol would be a good one, right? So those would all be fine to give because they're going to be more selective for beta-1 receptors. That makes sense. Who else would you not want to give a beta blocker to? Who's having an MI? So if they are having an issue, when they're hypotensive, if they're bradycardic, that is not something you want to be giving an additional beta blocker on top of. Right? So a lot of people say, well, give them a beta blocker. It's like, well, their heart rate's like 40 and they are cold and hypotensive. That's not the time to start the beta blocker. Give them some time afterwards, once they've recovered, then you can consider starting. So think of the clinical setting, right? You kind of think what their vitals are doing, and if it makes sense to give a beta blocker at that time. That's something you can hold off until they've kind of stabilized out. But we do know it's good to get started relatively early, if possible. So as I mentioned, aspirin, obviously if they have any allergies, recent GI bleeds, right? Because what effect would this have on GI bleeds? It's going to potentially worsen that because, again, remember that it's going to have an antiplatelet effect. So it could see that as being an issue. Intracranial hemorrhage recently, that would be another contraindication. Really, any kind of bleeding propensity, this is something you want to keep on the back of your mind. But again, it's good because it's going to prevent recurrent ischemia because it's going to help to prevent any further platelet aggregation from occurring if possible, right? Now again, the nitrates, typically you're starting with the sublingual. You get that going until EMS arrives, and if they need to, they can either keep giving the sublingual or they can switch over to IV potentially. Once they get to the ER, they might be switching over to the IV infusion. It depends on what their blood pressure is doing. It depends on the chest pain, because we'll see that this is not the only medication that we have available to us in order to treat the chest pain. We'll look at some alternatives here in a second. But again, who might be precluded from getting IV nitroglycerin? Well, if they're already hypotensive, you probably wouldn't want to give any further nitroglycerin, right? Even if they're still having chest pain, we'll give them other stuff for that. Because if you cause them to be more hypotensive because of the nitroglycerin, what does the heart rate want to do in response to that? Speed up. And what does that do to oxygen demand by the heart? It increases. Is that good for someone who's having ischemia? Not generally, right? So one thing to consider with that, we talked about the phosphodiesterase inhibitor contraindication there. But again, no mortality benefit, but is good in terms of helping to relieve some of that pain the patient's experiencing. I mentioned beta blockers. Typically, you can start off IV. So if they come in and they're hypertensive, they're tachycardic, this is a good time to start a beta blocker. That'd be totally reasonable to do it in that case there. But if they have any sort of severe reactive airway disease, obviously use a beta-1 selective agent, as we mentioned. Be careful in patients who are hypotensive, bradycardic, they have heart block. Avoid using it in those cases there, okay? Now, what do we do if they still have pain? What can we do for those patients, right? You guys have heard of MONA, correct? What is MONA? MONA-Me, right? Morphine, oxygen, nitroglycerin, aspirin, right? Those are the four you're going to be giving to your patients when they're experiencing this chest pain, right? So oxygen, obviously, to help just get as much oxygen as possible to the heart there. Nitroglycerin to help out with the chest pain. The aspirin, as we mentioned, to help prevent further platelet aggregation. What's the morphine doing? Helping with pain relief. So if the patient gets good relief with nitro by itself, do you need to give any morphine? No, not necessarily. Now, is there anything magic about morphine that I could maybe not give any other opioids? Nothing, right? Because there's some patients who cannot receive morphine, right? We'll talk about some cases here, and we'll dive much deeper into the other opioids when we talk about pain management next semester, but we'll mention morphine here. Now, how do opioids work? So they're opioids, and we have natural opioid receptors. These then go and activate that, right? So if you ever hear of a mu or a kappa or a delta opioid receptor, We're talking mainly about the mu receptor. That's the big one we're talking about. Because what do we have naturally that activates those receptors? Endorphins and enkephalins and things like that. You ever heard about the runner's high? They're running for a really long time, they release natural endorphins and they get that high. I can guarantee that. I think that's a myth. I think as soon as I start running, it's the worst. It's just the worst. So maybe some people are more predisposed to that than others. But I'm just kidding. I know it's a factor of distance and whatnot. I just never got anywhere near that distance. You get to the end of the door and I'm just like, no, I'm good. I'll take morphine instead. That's fine. No, so it's going to act on those mu opioid receptors, and it's going to cause that significant analgesia that we're looking for there. So if a patient's still having pretty bad chest pain, irresponsive to that nitroglycerin, or if they're hypotensive and they can't get the nitroglycerin, the morphine's totally appropriate to give at that point there. Again, not useful in terms of any mortality benefits. It's really just for patient comfort there. Kind of a nice additional thing of morphine is it actually causes histamine release, which in some patients will lead to allergy, can lead to itching, things like that, which can be bad. But also histamine does what to the blood vessels? Actually can cause dilation, right? If you have histamine activation, that's why your nose gets all runny and stuffy and your eyes get hyperemic and all these things is due to blood vessel dilation due to histamine. And so that may actually be helpful somewhat with the blood pressure. It's not probably going to be the primary benefit there. But for patients who have a morphine allergy, that is notable that you want to avoid using this in those patients with that allergy. A lot of it could be related to that histamine. So it's not uncommon for people to get a lot of nausea, vomiting, they itchy with morphine. But if you switch them over to something else like hydromorphone or fentanyl or anything like that, any opioid is going to be fine here because you're just using it for that, the actual pain relief. Okay. And again, we'll talk more about the opioids later. Just know that morphine causes that histamine release, and that's something we'd be watching out for. Okay. Make sense? Okay. So anyway, so we talked about our clotting cascade and medications are going to be useful here. So we mentioned the big classes are going to be what? Heparins are low molecular weight heparins are going to be kind of the big ones we're going to be shooting for here. And remember, low molecular weight heparins, how do their activity differ from, say, unfractionated heparin? So they focus more on, the low molecular weight heparins focus more on 10 and 2 with a preference for 10. Heparin's going to be a little bit more broad there, right? So, and remember how the dosing differed between the two? Any kind of like broad strokes of that?
Q12 versus 24 for heparin and
Sort of. So heparin is typically given when you're using it for a therapeutic purpose. So we talk about prophylaxis versus active treatment. In this case here, we're doing it for active treatment, correct? The patient's having an acute coronary syndrome. So when you use heparin, it has a fairly short half-life. We have to give it via a continuous IV infusion, right? So that's something to note with that. It's going to be continuous infusion. What are the benefits of using a continuous infusion of a short-acting medication? You can titrate it very easily, right? So and how would I monitor for the effects of heparin? APTT most commonly. You could also use anti-10A, but APTT is the historical norm. And so you would find that you can dial up and down your dose as needed as soon as you get that APTT back, right? So if it comes back too high, turn it down. If it comes back too low, crank it up. And it's fairly easy to titrate from that standpoint. However, there is a lot more of that monitoring associated with that versus your low molecular weight heparins have a longer half-life, and so you only maybe give Q12-hour dosing for that. However, once it's in the system, that's kind of it. It's there, right? So it's something just to kind of keep in mind in terms from a dosing standpoint. So now let's talk a little bit about the fibrinolytics. So this is kind of the new class that we haven't really touched on too much lately. And so there's a couple of different drugs here. We'll find that TPA, as you mentioned, is probably one of the most common ones. Have you heard of any others? Urokinase, streptokinase, tenecteplase. We'll talk about a few here. TPA is probably one of the more common ones you're going to run into because not only do we use it in cases of acute coronary syndrome, but we can also use it for what other purposes? For stroke, if you have a hemorrhagic or ischemic? Ischemic, right? Because you can actually give them a hemorrhagic stroke by lysing all that fibrin. That's not good. So you always want to get that CT beforehand, right? Make sure they have a big bleed in their head. What other things could you use it for? PE potentially, yeah, if they're having a massive PE, you could potentially use TPA to get rid of that. Far and away, the most common reason that we use this is probably for actual intracatheter embolization, right? So if you have, say, a central line in a patient, and that blood can pool there and it can clot off, right? And so is it real easy to change out a central line? No, it's a big process, right? And so you want to keep those good as long as you can. So sometimes, you know, if a nurse is trying to give a medication but they're not getting any flow through that catheter, they'll actually use TPA to actually lyse that a little bit. They use very small doses, obviously, but it'll lyse that clot that's right there in the line and hopefully get better flow established, right? That way you can save the line, hopefully. So again, we'll see some different uses here. We'll talk about how it works in just a few moments, but again, just know that plasminogen is normally the inactive form of that that's kind of normally circulating around, and then we're going to be stimulating that conversion over to plasmin through tissue plasminogen activator, right? And so there's some other factors that come into play here, things like streptokinase that can form some, basically they kind of help with the activation steps, and I'll talk about that in just a moment here. I'll show you kind of a graphic there. But again, there's different roles here, and this is why we use different medications to kind of just stimulate that process of ultimately converting plasminogen over to plasmin. So you can see here how streptokinase, plasminogen kind of come together to form this complex, and then that will then further progress plasminogen converting over, or you just have TPA or something like urokinase directly stimulate that conversion over to plasmin itself. Okay, that's kind of the general process for how we're getting that. Now, the three more common ones we're going to find being used include TPA, redoplase, and then tenecteplase. This is nice because it actually has a preferential effect for only activating fibrin that's bound to plasminogen. So why do you think that's a benefit? Yeah, you're hopefully going to be targeting right where the fibrin is most prevalent, right? Those places you don't want it to be. If you were inactivating circulating fibrin that may be in other places you don't want it to be, then that could increase your risk for bleeding, right? So that's one of the big things you're going to see with these drugs here, is that obviously the biggest side effect is bleeding, potentially fatal bleeding in a lot of cases. So you have to be really careful with these drugs. This is not something you want to be handling lightly by any means, okay? And so, as we mentioned, bleeding is going to be the biggest adverse effect here. You know, things like hemorrhagic stroke, you can find hematemesis. I mean, you can bleed from anywhere, basically, whenever you're administering these drugs, and that's the things you want to be really careful of. And this is why the contraindications, which we'll see in a moment, are so important to know, and you might get tested on it, potentially, so it's also a good reason to know it. I'll show this in a second. But also other things, because most of these tend to be a recombinant sort of drug, meaning we're having to make it we're trying to either make it synthetically or maybe we're using things like bacteria to help us make it. There is a risk for having more allergies to this. That's the one thing you want to know, because again, you don't want your patient to have an acute coronary syndrome and then now you got to treat anaphylaxis on top of that, right? It's not ideal, but it is something to know. We'll talk about anaphylaxis and how we treat that later on. And then arrhythmias are also going to be a big thing to note here as well. However, what's the potential sequelae of having an acute coronary syndrome? Ventricular arrhythmias, right? So sometimes it's hard to tell, is it the drug, is it the patient just going into a ventricular arrhythmias? It can be difficult to discern between the two, but that is an association that we know of. Okay, so contraindications, these are things you want to really be cognizant of and make sure you mark down, because if you accidentally give one of these drugs to a patient with one of these contraindications and the patient dies, and the lawyers come after you and they say, well, why'd you give that drug? You say, well, I went through all the checklist and what about this one? And you say, oh, I forgot about that one. And then that malpractice insurance will be coming into play. You don't want that to happen, right? So these are things you want to be very watchful of, and this is why you are, and again, this is going to be more for systemically administered fibrinolytics, right? So if we're giving this for, say, something like an ischemic stroke, if we're giving this for something like a DVT, or not a DVT, but a PE, like a massive PE potentially, this is where we're more concerned with that. Because nowadays, when the patient with acute coronary syndrome, where do they typically go to? They go to the cath lab, right? However, if you were in a place like, say, you're in the middle of podunk nowhere and the nearest cath lab is prohibitively far away, you might have to administer this in case of acute coronary syndrome, right? What's nice nowadays, though, is you can actually give like catheter-guided TPA and things like that, which is much more kind of local and much smaller doses, and so the risk for bleeding obviously goes down pretty significantly. But imagine we're going to be giving a full systemic dose of something like TPA. These are the things you want to be watchful of, okay? And they're all usually related to risk for bleeding, right? So for instance, if they've had surgery in the past 10 days or so, if they've had serious gastrointestinal bleeding within 3 months, they have a history of hypertension, and so this is specifically with the diastolic pressure being above 110. Does that mean that any patient comes in with a diastolic of 115, they can't get the drug? Not necessarily. You can actually treat that potentially. So if I give them a dose of an IV antihypertensive, say something like an alloprolat, which is what kind of drug? It's ACE inhibitor, I could do that. I could give a beta blocker. I could give hydralazine. There's a lot of different IV agents you could potentially give to get that pressure down. And if you can get that successfully under the limits, then you can actually still give the drugs. That's one thing that's kind of a relative contraindication. Obviously, they're actively bleeding. You probably don't want to cause them to bleed any worse because of that. Previous CVAs, if they have a tumor potentially, aortic dissection, pericarditis, if they've had any previous allergic reactions, or if they are pregnant. These are all cases where you would not want to administer a fibrinolytic, okay, because the risk for bleeding outweighs potential benefits, okay. STK is streptokinase, yes. Probably list out my abbreviations, but thank you for mentioning that. So as I mentioned, Alteplase is going to be at least the one I see most commonly being used here. Notice it's made with recombinant DNA technology, and again, whoever figured out the Chinese hamster ovary cells happen to be the most effective way to produce this, I have no clue. I don't know if what African hamsters do any better or worse, or Antarctic hamsters. I have no idea, but Chinese hamsters tend to be the best one out here. I noticed that I said 2 continents instead of just a country, but China's pretty big. It's kind of, I don't know. Anyway, geography is not my strong suit, which is why I landed over here. Anyway, these drugs are also pretty expensive just because the production of it tends to be very expensive, right? Anytime you're using things or recombinantly making them, they tend to be expensive, so you always also want to keep that in the back of your mind. But again, this is nice because it's going to directly bind to that plasminogens found in the fibrin, so it's going to be a little bit more specific instead of kind of binding it elsewhere to increase that risk of bleeding. Retiplase is made from E. coli cells, it's another recombinant form there, and then tenecteplase would be another one. Again, sometimes these products are kind of similar to our own natural proteins, but we just change out some of the amino acids. You'll see that a little bit more when we talk about insulins and things like that. But again, you can find that some of these may have some benefits. Again, for my purposes, I mostly see Alteplase being used most commonly. I don't know. I think I've used tenecteplase one time for an ACS case where the cath lab was not going to be an option, but again, it's few and far in between. Other things to note here is also going to be the time, right? The timing is going to be important here because the further out a patient gets from having that initial onset of ischemia or infarction, you're going to find that the benefits of using a fibrinolytic goes down with time and the risk stays the same roughly. And so in these cases here, especially with older patients who are more at risk for bleeding anyway, so for instance here, less than 75 years within 12 hours of symptom onset, that's going to be kind of your window for that. If it gets beyond that, then the benefits are going to start to decrease over time, where the risk stays the same. Or for instance, it's even less time for, say, a 75-year-old or older. So just be aware of that. And then, as I mentioned, in terms of systemic administration, relatively few patients get this, but you still want to be familiar with it because, again, if you're working in the hospital, you'll probably use it most for intracatheter thrombolysis most commonly. And again, bleeding risk is going to be the biggest thing here. Intracranial hemorrhage between 0.4 and 0.94% here, so anywhere between, say 1 out of every 100 patients that receive this has intracranial hemorrhage. Does that sound like pretty good odds? I wouldn't want to bet on that, right? So, so because of that, 1 in 100 to have a head bleed, I probably wouldn't do that. 1 in 1,000 maybe, 1 in 1,000,000, yeah, for sure. Not 1 in 100. So that's why we like to prevent giving this systemically if we can. Okay, so other agents we talked about. Most of the time you're going to see these being used in conjunction with some of the other agents in patients going for percutaneous coronary interventions, right? So most patients end up going to the cath lab. This is where you see your 2B3A inhibitors. For acute coronary, so for STEMI specifically, you don't see 2B3A inhibitors used as commonly, but certainly you'll see a mixture of the ADP antagonists used along with something like heparin potentially, used along with aspirin. It just depends on the case there and what they're looking for. And when I say ADP antagonists, we mentioned clopidogrel, but what are the others we use? There's prasugrel and then ticagrelor is the other two. Those actually have even better platelet inhibition than clopidogrel, so those are starting to get used more and more frequently than clopidogrel nowadays. And then also, you can continue on those for long term. Those are all oral agents that may be on for sort of maintenance therapy. And again, when you put a stent into a patient's coronary vessel here, do you think the body likes having that little mesh there in the vessel? Not really. Platelets like to bind to that, right? So anytime you have foreign material in the body doesn't normally like that. So in order to, and again, this could just be a bare metal stent, or it could also be what? Kind of a drug-eluting stent where it can release some certain medications there to try to prevent restenosis of that vessel. And so in these cases here, we like to give antiplatelet therapy to prevent any platelets from aggregating onto that wire mesh. Okay, so that's another thing you'll see more on the long-term side of things. Does anyone know any prominent public figures that have recently had a stent placed? Bernie Sanders, absolutely. I think he had like 2 stents placed. Is that the case there? I don't remember. But anyway, so he had 2 stents placed, and so I was like, oh, maybe he's taking clopidogrel or something right now because of that. Who can say? Anywho,
Sanders.
huh?
Probably Sanders.
Well, yeah, Bernie Sanders could likely say, or his physicians perhaps, or maybe he has a really kick butt PA.
Probably.
Dose them just appropriately, right? I can't say.
Progressives.
Yeah. Anywho, so getting to the non-STEMI, so again, either non-STEMI MI or unstable angina, and when I say unstable angina, that just means what? It's just being at rest, right? So early treatment is going to be the same, right? So you're still going to give the nitroglycerin, still going to give the aspirin. Beta blockers can be useful here. Typically, fibrinolytics are not going to be used for NSTEMIs, mainly because the risks just stay outweighing the benefits for the most part there. We may use a little bit more of the low molecular weight heparins, depending on the case, and then we see more of the 2B3 inhibitors being used when they go for PCI. Yeah. Those are the big differences. So any questions on that? Really, fibrinolytics are going to be kind of the biggest new medications from that group there. Again, like if a patient, if I ask a test question, patient's starting out with chest pain, what's sort of the list of medications they should get? What might they be contraindicated from receiving? Those are things I might ask about, right? So if I say a patient coming into the emergency department, their blood pressure is 70/30, should they get nitroglycerin? Probably not, right? So those are things we might want to stay aware of, right? So let's get into heart failure. So this is a common sequelae of things like an MI, right? And so we're also going to see that other things can cause this, including hypertension. There's actually some medications that can actually lead to this. When we talk about oncology, there's a group of medications that can lead to a cardiomyopathy and lead to heart failure. Anyone know what those are by any chance? You guys haven't covered any oncology stuff yet, right? No, we'll talk about doxorubicin and daunorubicin. Actually, an interesting one, you guys ever heard of Ipecac before? What is Ipecac? So it used to be something we'd use way back in the days, the old-timey sort of drug use. But basically, if you had a kid that like swallowed a medication on accident or something, we would actually give Ipecac as a home remedy that we give in order to cause the child to vomit. Right? You guys ever seen Family Guy in the thing where they all drink Ipecac to see you can hold it down longest? That's essentially what we were doing to little kids. Obviously, we realized after a period of time that's not really that great. It's not very effective. And then also, what do you worry about when you're throwing up? Aspiration is also another big concern. We stopped using that. However, we actually had cases where young people were abusing Ipecac for what purposes? For bulimia. They wanted to lose weight because of that. However, Ipecac actually had a really nasty additional chemical in it that actually led to a cardiomyopathy. So you'd have these like young ladies or young gentlemen who were coming in who were very thin, were bulimic, but they had these like massive hearts, and they couldn't figure out why until they realized that it was actually having to do with the Ipecac that they were abusing. So again, another reason why they got taken off the market and you can't really find that stuff anymore. But anywho, again, so there's a lot of different etiologies, and the easy stuff to rule out, rule in potentially, depending on the presentation there, right? So anyway, so what we're going to see with these patients here is a lot of systolic dysfunction could be related to decreased contractility. We know over time that left ventricle is going to get overworked, it gets stiffer, it gets more hypertrophied, it's just not going to be as compliant, and so we can see some issues there. Certainly there's different etiologies, where it can be hypertrophy, it could be dilated, a lot of things there, but for the most part, we're going to be assessing this as having a reduced ejection fraction, right? But the diastolic dysfunction tends to be due more so to the decreased relaxation here. Again, that's where you get those really thick, stiff ventricles. They're not going to be really that compliant there. A lot of that has to do with ischemia as well, which you'll see, especially post-MI. So those are the things that we're going to be focusing on. And again, you'll see the treatment may differ a little bit if it's more of a diastolic versus systolic sort of issue here. Anyway, so what are some compensatory responses? If our cardiac output's not great, what are we going to do to try to increase oxygen and blood delivery throughout the body? We're going to do things like try to increase maybe blood volume, right? So that way we can get more blood kind of flowing around. So we can do things like increasing water and salt retention. How do we do that? The RAS system, remember, renin-angiotensin aldosterone system is going to be coming into play here. You've talked about heart failure already, right? Mm-hmm. So what are some medications these patients need to be on? ACE inhibitors, right? ACE inhibitors are going to be good for helping. We'll talk about loops as well. But that's something that they may need to be on, but this ACE inhibitor is definitely something they have to be on, right? At least according to guidelines. We'll talk about why that is in a little bit. But you're going to see, reflex vasoconstriction. You're going to be seeing further hypertrophy of that left ventricle. A lot of it has to do with increasing the afterload, and then as a result, we're going to get increased preload as well. So you're going to be kind of fighting it on kind of both ends of the scale there. And again, notice here it's kind of a cyclical sort of pattern here where when you have decreased cardiac output, you're going to be decreasing the perfusion. Thus, that increases renin-angiotensin system, which further increases sodium and water retention, which causes more congestion, which can then further decrease cardiac output, and blah, blah, blah. You know, it just goes in the 6 cycles. So we have to interrupt it somewhere in order to make sure that we get the patient kind of able to get an appropriate cardiac output. And hopefully, because, you know, can you reverse any damage over time to the heart? Not really, right? What can we do, though? Slow down the progression, right? So that's really the big thing we're focusing on. We're trying to keep the heart as functional as long as we can for these patients. So other common precipitants or reasons why patients who maybe have a stable heart failure but then they decompensate, because this is, if you're working in the urgent cares or ERs, this is a frequent presentation here where a patient with chronic heart failure, they come in for an acute episode or an acute decompensation. And so a lot of this has to do with things like lack of compliance. So compliance with what? Not just the ventricle, right? So we know that's their kind of their baseline, but in terms of what their behaviors are. Medications and the diet could also be another big thing as well. So they're like, yeah, I went to a hot dog eating competition and ate my body's weight worth of salt, and so now I'm decompensated. They usually don't present and say that specifically, but you can kind of dig down and be like, oh, okay. Again, other things like dysrhythmias, uncontrolled hypertension, etc. All these things can be really kind of leading into these decompensations. It could be multifactorial. It could just be one of these things, depending on the case there. And so looking at non-pharmacologic therapy, how can we help to manage these patients? Obviously, dietary sodium and fluid restriction are going to be big things here. So if we can keep down sodium intake, maybe like 1 gram a day, maybe up to 3 in some cases there, that's going to be useful because less salt being held in the body means what in terms of fluid? Less water as well. So that's always going to be a good thing we're focusing on. And again, encourage that physical activity to try to help with that functional status, try to help out with exercise tolerance. That's always going to be good for them, which may be pretty limited for some of these patients. But let's get into talking about the medication specifically, right? So here in terms of diuretics, what are diuretics going to do for us with a CHF patient? They're going to diurese the patient, they're going to get rid of that fluid, okay? And so how do patients monitor if they have fluid overload or not? How can they do it at home? So they can see it potentially, they just know their ankles are swelling up, right? So they can see it or feel it. What are some other more objective measures? Their weight, right? So this is why you want these patients getting like daily weights and kind of monitoring that, because you'll see that as they put on pound after pound after pound, they're probably, most of that is water weight, right? And so that could be indicative of they may need to take their water pill, so to speak, and get on their diuretic in order to help get rid of that extra fluid there. So anyway, so is this going to help more with like a preload or an afterload issue? Yeah, it's outside the preload. It helps with that congestion of all that fluid that they're building up on the venous side of things. So thiazide diuretics, typically not potent enough for most of your heart failure patients, right? Now they may be on a thiazide for what purposes? For the hypertension, right? So that could be one thing, but you're not going to see someone who's taking a thiazide specifically to get rid of a lot of that fluid there, because again, usually the compensatory mechanisms of the kidneys make it such that the thiazides are not going to stay potent for very long. However, your loop diuretics are certainly going to be most beneficial here, and that includes which diuretics? Furosemide, bumetanide, torsemide, and ethacrynic acid, right? Because that one just wanted to be different, right? In terms of naming convention. So those are your main 4 loop diuretics. Obviously, the most common one you're probably going to run into is going to be furosemide or Lasix. And so this is one of those things where if like you see someone taking a thiazide, would you think it'd be normally scheduled or PRN? Usually scheduled, right? However, for something like a loop diuretic for these patients here, what do you think, scheduled or PRN? It could be PRN, right? So you could see that some patients may just need it chronically, so they may be on a schedule, but a lot of patients will say, hey, go ahead and take this, take 20, 40 milligrams, whatever the case may be, as needed to help monitor that weight, right? So hopefully they can see a direct output in terms of them taking the water pill to seeing how their weight is going to change the next morning, and that way they can kind of keep an eye on things, right? What are some of the risks of giving someone a loop diuretic with heart failure? Dehydration could be one thing, right? What else? Maybe hyponatremia. More commonly, though, what goes along with the sodium? The potassium is another big thing, right? Hypokalemia is a big occurrence with this, right? And why do we care about hypokalemia with heart failure patients? Arrhythmias are going to be a risk, right? We'll talk about antiarrhythmics in the next section, but those are the concerns you have with that. Also keep in mind you're losing magnesium as well. You're going to be losing some calcium, so those are all electrolyte balances you're going to be finding shift when you have someone who's on a loop diuretic chronically. Now remember, you can't have patients who actually develop what they call loop resistance And remember when I talked about that, what that means?
Yeah. They're resistant to it, but you add in a thiazide and not
Yeah.
stop.
Right, so remember how things go. Remember the loop diuretics work in the ascending loop of Henle, but after a while the kidneys can compensate and try to increase reabsorption of water and salt at the distal convoluted tubules. What do you do in that case? You add on a thiazide diuretic and you get some additional benefits there, right? If I had a patient who had concomitant renal failure along with CHF, what thiazide diuretic would be reasonable to use in them? Remember, most of the thiazides don't work when you get down below like a creatinine clearance of 30. Metolazone still works, right? That's still the one you want to make a rock urinate, right? However, do loops stay effective even at low creatinine clearances? Yes, you can give them regardless and they'll still stay effective, right? So that's one kind of differentiation between that. And again, so in terms of monitoring though, that's what they're going to be using is using their weight to see, hey, if I'm getting more than a pound a day over several days, they probably need to add on that loop diuretic to try to get rid of some of that extra fluid. And again, the diuretics typically for symptomatic relief only for the most part, no evidence of it actually decreasing mortality or anything like that. However, it could be something that could lead to a decompensation if they're not taking it like they should. So that is one thing to note there. And again, it's not mandatory that every single patient has to be taking this every single day, right? Specifically the loop diuretics in order to manage that fluid. If they're at a dry, close to their dry weight and they're not really having any edematous issues, they don't have to take it necessarily. However, ACE inhibitors are going to be mandatory therapy for the majority of these patients here, right? So they're going to help with decreasing preload, afterload by interrupting that RAS system there. Now, what effects would an ACE inhibitor have on, say, potassium?
Increase it.
Why does it increase it? Right, because it's stopping the activity of aldosterone, right? Remember, when aldosterone's working, you increase sodium reabsorption at the loss of potassium. Where does that work at in the kidneys? In the collecting duct, right? However, if I interrupt that by introducing an ACE inhibitor, decrease aldosterone activity, thus you're going to be causing more potassium reabsorption and you're losing more of that sodium in the urine. So already you can start to see a balance here between the potassium, and that's why it's really important. I'll probably ask a few questions. I'll probably ask some on the last test. I'll probably ask them again on this test. It's like, which of these drugs are going to cause, the potassium to go up or down? Which of these drugs is inappropriate for someone who has hypokalemia or hyperkalemia, right? Because these are common drugs patients are on. So when someone presents and their K is 6, you need to have a good reason why that is. Is it because their kidney function is poor? Is it because of their medications? Is it because the blood hemolyzed in the lab? What's the reason for that? And you can identify this if you know the drugs, at least from my standpoint, right? Anyway, other benefits of ACE inhibitors, what are they going to do for us from just managing the blood pressure? That's that left ventricular remodeling effect, right? This is why it causes decreased progression of heart failure symptoms. This is why it decreases mortality. This is why you need to have an ACE inhibitor on board, right? Now, who might be an inappropriate candidate for an ACE inhibitor? So, history of angioedema would be one, right? Or maybe if they can't tolerate it because of the cough, that'd be one thing. Now, heard kidney dysfunction, heard kidney failure, right? Why would that be an issue? Because it can cause an acute decrease in GFR when you give an ACE inhibitor. Does that mean they cannot receive this drug? They still need to be on it, right? So it just means you need to be cautious with it. And what's the mantra? Start low and go as fast as possible. No, I'm sorry. Start low and go slow, right? That's always going to be the mantra for these patients here because they can be quite sensitive depending on age, depending on what their EF is like. So start low and go slow is going to be the big thing here, right? We'll see that again when we get to like beta blockers and other things that seem like they should be contraindicated, yet are definitely indicated for these patients, right? Anyway, if they could not receive an ACE inhibitor, we can use it as an alternative. An ARB, right? So ARB would be totally appropriate to switch over to if an ACE inhibitor was not going to be appropriate here, right? And again, we've seen all these different benefits with ACE inhibitors. This is why we like them. This is why it's going to be typically mandatory therapy unless they have a really, really good reason not to be on one. Okay, as I mentioned, you can see an acute impairment of renal function, but that's going to be something that can be overcome by, again, titrating very low doses and gradually working their way up. Obviously, watch out for their blood pressure, look out for potassium levels, and then remember the cough being an issue because of what? Yeah, that bradykinin buildup, which also leads to the angioedema, so those are things to be watchful for. Now, what about beta blockers? Now, would beta blockers seem to make good sense in a heart failure patient? Why not? Yeah, because they're negative inotropes, so decrease contractility. What else do they do? Slow down the heart rate as well, right? So they're negative chronotropes, right? So they do both. And so because of that, it seems like, well, that would be a bad idea to start a beta blocker on a heart failure patient. However, chronically, we do find that certain beta blockers tend to be beneficial for these patients here. And in fact, the three you'll see most commonly used are going to be carvedilol, which is what kind of beta blocker?
Gen 3.
Yes, the third generation was some additional benefit for carvedilol. Had a little bit of vasodilation because it blocks alpha-1 receptors, so that was kind of an additional benefit there. Still not considered to really be a selective beta blocker, so you got to be careful with asthmatic patients here. But certainly metoprolol and then bisoprolol are going to be two that are also going to be indicated for heart failure. Okay. Now specifically, the metoprolol is going to be the succinate form. The other salt of metoprolol is the tartrate. So metoprolol tartrate, metoprolol succinate. Remember that the succinate form is the extended action one, right? So I like to think about sucking on a hard candy. Suck on that for a long time. Metoprolol succinate lasts for a long time. That's kind of the way I think about that, right? Or maybe I'm progressing to an old man. I have like my pockets are always full of Werther's originals and like hand them out to everyone. But
tarts go faster or something.
Hey, maybe tarts go faster. I can think about like a warhead. Like those things are like really tart and they just yeah, it's gone for 5 minutes or so. But anyway, so whatever association you have to make, remember that the metoprolol succinate is going to be the XL formulation of the drug. That is the one specifically indicated for heart failure. So those three are going to be beneficial. Now, again, what are the risks of giving a beta blocker to a heart failure patient? It's going to slow down the heart rate. It's going to decrease contractility, so you can see an acute decrease in their EF, right? So again, these are typically drugs you're going to be starting off like in the hospital. They need to be stabilized before you start these. They can't be on an acute decompensation and then you start them up on it. And so you, again, gradually work them up to a dose that they can tolerate. Again, you will find that they'll have better exercise tolerance. They're going to have decreased hospitalizations, mortality's better over time. And so again, these are really good drugs. Again, look, 6 to 8 weeks just to titrate them up, which is very long for in terms of medications, but that will help to prevent them from having that acute decompensation if you were to start them with like a full blast dose, right? Again, benefits here, you mentioned, again, lots of good reasons to start a beta blocker. So now we have 2 drugs. They're a good mandatory therapy for these patients here, ACE inhibitors and beta blockers. And now you're starting to see why like older patients, polypharmacy is kind of the norm, right? So we're starting to see, well, if you have a previous MI, now you have heart failure because now you're on aspirin, now you're taking a beta blocker, now you're on ACE inhibitor, now you have as needed furosemide for your, to watch your weight. What else are we going to add on?
You're hypertensive now, so you need Minidrin.
No, probably not, right? These patients are usually pretty hypertensive. And again, you're kind of balancing all these things out, right? So again, if they get too hypotensive, maybe back off on one of the medications there, right? Look at the heart rate. Are they adequately beta blocked? If not, then maybe go up on that, right? So it's a balance between these patients, which is why it gets so complicated when they're seeing multiple specialists, and you might be that one central person that kind of gets them, and you see like, well, why are you on this medication? Oh, it's because they're treating a side effect of this other medication that's prescribed by someone else, and so sometimes you have to like kind of take a step back and say, okay, let's reevaluate this whole thing here and see what we can do about it. Okay, so as I mentioned, these are going to be first-line therapy for class 2 to 4 heart failure, and they should be on an ACE inhibitor and a beta blocker irrespective of symptoms, okay? Again, how you work them up to it is going to be on a case-by-case basis, but they need to be on both of those. Okay, so digoxin is going to be a bit of a spicy meatball, so I'm going to give you a 10-minute break, and we'll come back and get started on that. All right, let's get back to it. Any questions from the first half? Nothing at all. Everyone feels pretty comfortable with the med so far. We barely covered any new drugs. This is perfect, right? It's all a nice review from last test. Now this is a new one, right? So we have digoxin. This is actually a very old drug. It actually has some plant origins. I know what plant you can find digoxin in. Foxglove is one. There's lily of the valley. Coincidentally, it's my oldest daughter's name. Toxicology reference, you know. That was actually, my wife just wanted to pick that name. And I was like, you know, there's going to be like 40 other lilies in her class with her. And she's like, yeah, I know, it's fine. She'll be basic, it's fine. But more important to Florida, we actually have oleander here, which is a source for digoxin-like compounds. So if you're ever driving down the, like one of the turnpikes or the interstate or something, you ever see those plants in the medians, like nice pink flowers or something, those are oleanders, and those actually contain digoxin-like compounds. So a little bit of trivia there, again, to wow all of your friends and relatives when you see them, whenever you see them. So yeah, whatever your fancy parties. We'll be having your tyramine-containing H cheeses and meats, and you can wow them with your knowledge of amateur botany, right? So, anywho, So this is an important one. So the drug's been around like for forever, and back when like CHF used to be called dropsy, so we've been using it for a good long time, and its use has kind of changed over time, as we'll see, due to some of its actions there. So at the kind of the bare minimum, what digoxin does in terms of mechanism is it inhibits the sodium-potassium ATPase pump. Okay, what does that sodium-potassium ATPase pump do for us? It's useful for action potentials. It pumps sodium and potassium. So where does the sodium go? Against the concentration gradient. So it goes in or out of the cell? Out of the cell. And pumps potassium into the cell. Is that against the concentration gradient? Yes. The mnemonic I always liked to teach when I was doing physio back in the day was our cells are like salt-wrapped bananas. For whatever reason, that's always stuck with me. So there's a lot of sodium on the outside of a cell. There's almost an equal amount of potassium inside of the cell. So that's how I remember potassium comes in, sodium goes out. Anyway, why are sodium potassium pumps important for our cardiac cells? Yeah, what do they do with the action potential? They maintain the resting membrane potential, okay? So after you've had the depolarization, you've repolarized, and we'll get more into that when we get into the antiarrhythmic section coming up. We'll see that the sodium-potassium pump is the thing that maintains that normal resting membrane potential. Why is that important? Because it keeps them ready for the next action potential to come along. If you have an altered resting membrane potential by maybe altering potassium levels or altering sodium levels or doing something, or maybe inhibiting the sodium-potassium pump, you're going to find that you can increase your risk for things like dysrhythmias. Okay, so one of the things that digoxin is going to do is just because it inhibits that pump, that's not really its therapeutic mechanism of action. What actually happens though is that you have patients who will have CHF, and again we said what's kind of the hallmark in terms of their contractility. The CHF is diminished, right, for the most part. So what this is going to do is by basically inhibiting this pump here, what do you think it does to intracellular sodium concentrations? They'll increase, right, because there's not as much sodium being pumped out of the cell, okay? So what does it do over here? Well, if downstream over this way, you can see here, by increasing the amount of sodium within the cell, it's going to be increasing this activity, this pump here. So sodium goes out, and then calcium comes in. Well, why does calcium matter? That's what causes the contraction. So by including more calcium into the cell, what does that do for the force of contraction? Increases it, right? So this is why we use it for a long time for CHF, is it would basically increase intracellular calcium and would cause stronger contractions. Thus your EF should go up in those cases. You should be able to perfuse better. So that's how it's used for a long time. We'll see how it's changed as well. Now what would happen to, say, potassium levels by inhibiting this pump here? So if I can't bring potassium into the cell, then hyperkalemia. So you'll actually see that hyperkalemia is another thing you'll find with digoxin use, because basically you're preventing it from getting back into the cells. So it's going to stay on the outside more. And what's a normal potassium level?
3.5 to 5.
3.5 to 5. And then if you start to get up to like say 6 or 7, that could be related to digoxin. We'll see some other reasons why it could be related to that as well. So anyways, that's kind of the mechanism there. So it's a stronger inotrope. It's going to bring calcium in. It's going to cause a stronger contractions for that. So it's a positive inotrope or chronotrope? Inotrope. Okay, good. Now, the newer mechanism why we think this is useful for CHF is going to be this neurohormonal effect. And if you looked back at the structure, so I kind of had that 4-ring structure that kind of looked like other steroids, like cortisol or testosterone and things like that. It had that same kind of basic core. And so what it actually will help with is decreasing sympathetic activity, which is usually ramped up because of what in these patients? The renin-angiotensin system tends to ramp that up. It'll increase parasympathetic activity. What do you think it does to something like heart rate? Which will decrease it, right? So bradyarrhythmias are a common thing you're going to see with digoxin. It'll help to resensitize the baroreflex. Why is this important? What's the baroreflex do for us? Remember, the baroreflex test was checking the pressure in the vessels there, and when it gets, if you're chronically hypertensive, what happens to the set point of it? It goes up, right? So it says, hey, this is just normal now, 180 over 100. This is just my new normal, right? This helps to reset that a little bit, right? When you're introducing this along with other antihypertensives, and overall helps to decrease renin-angiotensin aldosterone activity. Actually, I did an interview just recently, and the student was a previous hyperbaric chamber technician. And so they came in, I was like, wow, it's pretty impressive. Used to work with hyperbaric chambers. You guys know what a hyperbaric chamber is? What do they use it for? Maybe athletes, right? Helps with wound healing. You also use it for like diving injuries because it puts them under like 2 to 3 atmospheres of pressure, right? So she comes in for the interview. I said, wow, that's pretty interesting. So you work well under pressure? Anyway. I can't tell you that because I don't want to give it away. I don't know. Maybe that's part of the criteria, maybe not. Like, so maybe not getting my jokes is an automatic no for me. I don't know. She got it at least, though. Okay. Not the interview necessarily. I can't say one way or the other, but she got the joke, so.
Yeah, that's what we wanted to know.
Of course, that's it. Anyway, I'm gonna cut all this out. I don't want anyone hearing this. No. Anyway, so again, those are some of the ancillary benefits of digoxin. So again, the contractility thing is kind of a value add, but it's the rest of this neurohormonal effect that is what's kind of causing most of our benefits for CHF patients. And actually it has to do with the levels we're looking for, because we're going to see that digoxin is one of those drugs that has a narrow therapeutic index. Remember what that means?
Yes.
You do drug monitoring for it, right? So we're going to be monitoring levels for these patients here. Anyway, so as I mentioned, you're going to get overall, by blocking that sodium potassium pump, it's going to help to reset the barrel reflex, so that also helps to decrease heart rate. You're going to find that increase in parasympathetic activity helps with the AV node conduction system. You're going to find that decrease in sympathetic activity will help with the heart rate and blood pressure, so again, some additional benefits there. And overall, you're going to get better pumping action, right? So if you decrease the afterload on the heart, what does that help the heart to do? Pumps more efficiently, right? It doesn't have as much pressure that it has to pump again. So again, all of these things are going to be beneficial for our patients. And again, the levels have changed over time too, because so before when we were using it for a positive inotrope, we would actually end up having to shoot for levels of like maybe like 1.5 to 2 or something like that. Notice here it's very small amounts, nanograms per ml. What's a normal like drug unit of measurement we would use? Milligrams per liter normally, or micrograms per ml. Notice here this is even a further order of magnitude, nanograms per ml. So it's a very small amount of drug you're having to give here, and we're shooting for very small levels. 0.5 to 1 is sort of a therapeutic level. Now I'm not going to ask you to memorize that level specifically. If I ask you a question on a test, it's going to be more to do with the interpretation. So I'll give you what the patient's level is and then what the normal is, and so you'll still have to make some interpretations off that potentially, right? So it's something that may come up. But anyway, what we do find is that when you increase the levels any further, we don't get any additional benefit, and you're only more likely to see what? Adverse effects from these medications, right? So some of the benefits we're going to see is that you'll get improvement in their heart failure symptoms. They should have improved exercise tolerance. So they should be able to get around a little bit better before they start to have, get short of breath. They should have better quality of life, hopefully, and decrease hospitalizations. However, they have not found that it actually helps out with actual mortality. So while it may be beneficial for some other reasons for patients to be on this, the mortality benefit just isn't there. So this may be one of those things where there's not a clear indication like a beta blocker, like an ACE inhibitor, but it could be a good value add once those other medications kind of get on board and they're stabilized. So as I mentioned, these are going to be good for patients who are going to be still symptomatic, even on optimal doses of ACE inhibitors, beta blockers, and diuretics. So it's kind of like a third or fourth line sort of medication to be adding on there. However, though, we will use digoxin frequently to treat AFib. And so if you have a patient who has HF and AFib, this can be useful for that. Right, so this will actually help out with those patients and help to control AFib. We'll talk more about this atrial arrhythmias a little bit later on. And again, this is also considered for patients with symptomatic heart failure and systolic dysfunction. Those are going to be your main kind of patients you'll see on that. So the toxicity is a big thing, though. So this is one thing you always want to be careful of, because there's a narrow therapeutic index. For some patients, it may just be so hard to get them in range without having these toxicities that it may not be really worth their time in some cases. Initially, you can see GI effects, a lot of nausea, vomiting associated with this. Very unique sort of things you'll see with digoxin, right? So of course, unique side effects you should always make note of, correct? So if you have a patient who comes in and they're complaining of like photophobia, they're getting all these like weird yellow-green halos around lights, that is very, very specific for digoxin, okay? So they get, what do you call that when you have yellowing of the vision? Xanthopsia is the term for that. What if you have bluing of the vision? Yeah, cyanopsia is what that would be called. Actually, sildenafil or some erectile dysfunction meds can actually cause that. We'll talk about that in the urology section later on. But so xanthopsia is one of those things. Anytime something changes color, always make note of that. Right? Anywho, so the yellow-green halo, especially around lights, that photophobia, those are pretty indicative of someone having too much digoxin on board. Other things you can find, though, can be some confusion, dizziness, etc. Even like some abnormal dreams can kind of get triggered off by this if the levels are running a little high there. Because again, sodium-potassium pumps, are they only located on the heart? No, they're kind of located everywhere, right? So you can see weakness because it's affecting your skeletal muscle. You can see it affecting your neurons. So it makes sense why you'd see these kind of effects here. The main really worrying thing I worry about, though, right? So sometimes patients will be complaining about things like the yellow halos, but the more concerning thing that may be indicative of their risk for developing cardiac toxicity, and that's the big thing I worry about. This is something that's going to kill these patients. And so one of the interesting things about digoxin is almost any arrhythmia that is possible can be caused by digoxin. There's a few that are going to be very specific for digoxin. We'll talk about those. But for the most part, bradyarrhythmias, sinus brady is going to be probably the most common thing you're going to run into. Why do you think that is? Because I'm decreasing activity of that sodium-potassium pump, so that's also responsible for helping us get back to that resting membrane potential. So you're sort of extending out how long that refractory period is for those cells. You guys know what a refractory period is? What does that mean? It's that period of time where it is more difficult to trigger off an action potential. So it makes sense that by slowing down that repolarization phase and getting back to the resting membrane potential, that would also slow down the heart rate as well. So that's why sinus brady is probably one of the more common things you're going to be seeing with that. You can also end up seeing these after depolarization. So PVCs is another thing. It could be indicative of someone having too much digoxin on board. So if you see PVCs, it's kind of telling me that the myocardium is kind of hyperexcitable and could be indicative of them being at risk for more serious ventricular arrhythmias. So just something to note with that. Now, contraindications to digoxin, these are good things to know because you want to know who not to use this drug in. If they already have advanced AV block, what do you think that is? It's just going to worsen that, right? Just like I mentioned in the previous slide. Severe bradycardia, any ventricular arrhythmia or PVCs, obviously you would not want to add on digoxin to this because that's just going to be potentially worsening those. Now, what about the hyperkalemia? It's going to increase that further, right? So if they already have existing hyperkalemia, and who might be at risk for having hyperkalemia? If they're on an ACE inhibitor, if they're on an aldosterone antagonist, if they have renal dysfunction, those are all good reasons for them to have a high potassium. This is going to exacerbate that, right? So it's only going to get those levels even higher. So,
can you say that list again?
Yeah, so for like ACE inhibitors can do it, ARBs can do it, aldosterone antagonists will increase potassium. What else do we talk about can cause increased potassium? Yeah, the potassium-sparing diuretics, so like your triamterene, amiloride, renal failure as well, right? If they have poor renal function, they're going to be able to clear that potassium as well. So those are the things. Hypomagnesemia can also be a problem here in terms of heart function and causing arrhythmia. Actually, magnesium, and we'll talk about this as an antiarrhythmic a little bit later, but magnesium is kind of like our body's natural calcium channel blocker. And so because this is also affecting calcium influx into the cell, this is where you can see some arrhythmias can be exacerbated by that. Obviously, hypercalcemia is going to be another problem because, again, that can lead to impaired ventricular function. And then things like Wolff, Parkinson, and White would also be a contraindication. So a lot of reasons why patients may not be a good candidate for digoxin, and this is just starting the list here. Now, what would happen if I had someone having too much digoxin effect and they are having toxicity? Well, we have an antidote for that, right? Now, whenever I mention antidotes, those are also good things to know, right? One is my personal interest, and two, I think it's also important to know, like, if you have a reversal agent, you should know what that is, right? So, for instance, if someone took too much morphine during their acute coronary syndrome, what do you give them? We'll talk about that later, but you give them Narcan. Have you heard of Narcan before? Yes. I think it's within the cultural zeitgeist enough to at least have heard of it. If we have someone who got too much heparin, what do you give them? Protamine sulfate, right? If they got too much warfarin, what do you give them? Vitamin K or FFP. Green leafy vegetables. Say, here, please eat this whole bag of spinach. It's, I can't eat this whole bag. And I was like, let me heat this up real quick, and they'll get it down to a very small amount, and just eat that. It would work. I mean, just take a little while. Anyway. So this one we actually do have an antibody to target against that. So what other drug do we talk about had its own specific antibody made for it? Praxibine. So yeah, it's the idarucizumab that was made to work against dabigatran, right? So again, whenever you see these, they're not super common, but it's good to know when they come up. So this one is called Digoxin Immune Fab, okay, FAB. This is going to be Digiband's another name for that. It's nice they didn't put a whole MAB on the name. The thing is, this is not actually you know, whenever you see MAB, it's a monoclonal antibody that we produce, like it's a synthetically made antibody. This is actually one that we've hyperimmunized an animal against digoxin and then spun that down, isolated it, and now we can give it to patients, okay? So this actually comes from an ovine source. Does anyone know what that means? It comes from sheep. So actually we've hyperimmunized sheep against digoxin. How would you do that? You go talk to Mary, get her a little lamb, and then give it small doses of the digoxin, gradually building it up, and eventually the sheep will then develop antibodies against that. We can then isolate those out. We do the same thing with certain types of snake antivenom as well, which we'll talk about in a later date. But basically, we'll hyperimmunize these sheep. We will get them get the antibodies, and then we actually will do some cleavage of it. What's the problem with giving someone an antibody? You can induce anaphylaxis, right? And so, like I mentioned with the monoclonal antibodies, it depends if there's more murine protein in them, if it's like a chimeric sort of protein. When I say murine, what does that mean? Mouse. So if our bodies don't like mouse protein, do they like sheep protein? Not in particular, right? So unless you really like, you know, lamb chops or something like that, but you know, pork chops, not pork chops. What's that one I'm thinking of? Mutton. Maybe if you like mutton, maybe you like lamb proteins, but you know, mutton. Never heard of mutton before? You guys aren't going to those fancy parties I've been talking about, obviously. Look it up. Anywho, so sheep proteins can also cause allergy here, right? But actually what they do is interesting, and again, I'm just doing this as a bit of a tangent. We can modify the proteins themselves such that they don't have as much of a risk for reaction, right? So if you guys remember your how the monoclonal or the antibodies are actually formed, right? So this is the antibody, right? Which is part of it is the FC portion. The bottom portion here is the AB portion, right? Actually, what they'll end up doing is they'll cleave off a part of this protein here, and that way it's a shortened bit, and so it's less likely for your cells to have a reaction against it. So we'll get the antibody from the sheep, cut off part of that, and then we'll give it to the patients, and it'll bind up all that digoxin, and it actually works pretty almost immediately. Once it binds up that digoxin, guess what? Patients coming out of that arrhythmia, the heart rate will come up, blood pressure comes up, they look good after that point. So again, digoxin immune fab, or Digiban, is going to be the antidote for digoxin toxicity, okay? Any questions about that? Again, I wowed you with all kinds of useless knowledge today, so don't ever say I never taught you anything, okay? Next up are aldosterone antagonists. This is also going to be one of those things where it's appropriate for some patients, but maybe not all patients, as we'll see here. So spironolactone and eplerenone are going to be the two aldosterone antagonists we've talked about so far. We found that if you give this to patients with grade 3 or 4 heart failure, there is some mortality benefits for them receiving this. So this is very specific for the actual grade of disability they have. However, who's it not going to be good for? Well, it's not good for patients with potassiums over 5. Why is that? This is for they're going to raise potassium, right? And then for serum creatinines of greater than 2.5. Now, what's a normal serum creatinine? Around 1-ish, right? You know, maybe up to 1.2, depends on the patient. But above 2.5, that's pretty significant renal impairment. You would not want to give this either. So again, because that can also worsen your risk for hyperkalemia. So other reasons why I would not want to do that. Now remember, it causes things like gynecomastia in men. Why is that? It's blocking aldosterone, but it's a partial testosterone agonist, right? There's testosterone receptors. That's why you end up seeing that. You know, females can end up having more masculinizing sort of effects. Just remember that using eplerenone is less likely to cause that. So that's why we maybe switch over to that for those patients there. I think I had a test question about that too, didn't I?
You did.
Something regarding that. Anyway. So again, here we're also going to find that not only are they working just specifically to block aldosterone just in the kidneys, but also some of the neurohormonal effects, right? So kind of working more centrally to help with some of that remodeling of left ventricle, and we do see slow progression. So if they've already have grade 3 or 4, that's the case there where aldosterone antagonist is going to be effective, okay? But again, this is really good to know who's a good candidate for a particular drug, who's going to be contraindicated from some of these drugs. So if I said, hey, you have a patient who comes in, they've got stage 4 heart failure, but their potassium is 5.5, what drugs do you not want to give them?
This one.
Aldosterone antagonists, what else? ACE inhibitors might be bad to start on that kind of patient. ARBs, digoxin, right, good. So these are, also you'd want them to not have potassium supplements, right? Because oftentimes when they're on diuretics like Lasix, you'll put them on potassium supplements to try to prevent hypokalemia. But if they have poor kidney function, then that may not be necessary, right? All just depends. So a couple other agents you're going to use here. So these are all been like chronic medications we've been talking about so far, typically orally used. These are going to be good. These are positive inotropes that are typically given IV for like an acute decompensation, right? These are given via continuous infusion. Two here we have is going to be milrinone and enamrinone, and these are actually phosphodiesterase inhibitors. You think, wait a second, phosphodiesterase inhibitors, where do we use these? Or what do we use them for? Yeah, we use them for erectile dysfunction. Oh, wait a second. Why are we using these drugs for CHF? Actually, there's different isoenzymes of phosphodiesterase. So the one that's useful for erectile dysfunction is called PDE5. PDE3 is going to be working more specifically within the heart and also on the blood vessels. So you're actually going to find that by utilizing phosphodiesterase, it actually prevents the degradation of cyclic AMP. And more cyclic AMP in the heart means you're going to get better inotropic effects. So these are going to help when you have that really reduced EF. This is going to help with getting the contractility back up. They're also going to have some vasorelaxant effects on the vessels too. So if they come in and they're hypertensive and they're trying to pump against all that afterload, this will help to relax that a little bit. However, if the patient's already hypotensive, this may not be a good option for them. So again, these are other things you want to consider. Who are going to be bad patients for these drugs? Who are good patients? So it's inotropic as well as being a vasodilator. So you're going to get direct stimulation of the vessels there. You're going to get a nice balance between arterial and venous dilation. Very good to get the blood pressure down. Again, we don't want these patients to be on it long term though, because there are some mortality issues that we've seen with that. So it's good to kind of stabilize the patient. You know, they come in for a decompensation. You give them the milrinone, kind of get their fluids all figured out, get their blood pressure figured out, and then you titrate off of this, right? Once they've kind of stabilized and are back at baseline. And good for short-term IV use for decompensated heart failure, not for good long-term use in those cases there. Because again, you can see things like arrhythmias, thrombocytopenia, so the risks kind of outweigh the benefits in the long term there. A couple other agents you could potentially use are going to be dobutamine and then dopamine. Now, you've probably heard of dopamine before, right? Who here has dopamine? All of you have dopamine, right? You're able to move around, right? If you didn't have enough dopamine, what disease would you have? Yeah, Parkinson's, right? So now in terms of your mesolimbic pathway and me activating that reward pathway, everyone's probably at a very low level of dopamine at this point. However, in probably 30 minutes or so, it's going to elevate quite significantly. So look forward to that, right? Anywho, so how do we use dopamine and dobutamine? So actually dopamine here, when we give it peripherally in an IV, it actually doesn't really make it up to the CNS. So actually we don't use IV dopamine for like Parkinson's disease. We use something else that we'll talk about later on. But dobutamine is going to be a selective beta-1 agonist. So what do you think it's going to do for us? For acute decompensated heart failure? It's going to activate beta-1 receptors. What do you think it does to inotropy? Increases the positive inotrope. What do you think it does to the heart rate? Should also increase it as well, right? So again, this is going to get that cardiac output up, which is the main problem with these patients there. No, it doesn't have any of that vasodilatory sort of effect. So if you had to pick between one of these two, say milrinone versus dobutamine for patients hypotensive, this would be a better option for them, right? Because this doesn't have any vasodilating effects, okay? Because it's very selective for beta-1. On the other hand, though, we'll have dopamine. And dopamine is kind of interesting because it has, depending on the dose you're administering, it actually changes its functions a little bit. So say low doses, like let's say for instance, and I'll just draw this out for you real quick. I know you like my drawings. So let's say you were giving a dose between 1 to 5 mics per kilo per minute. That's a horrible 5, but whatever, it's 1 to 5. It actually works on dopamine receptors. And so you end up finding that it actually can do things like enhance, say, renal blood flow, things like that. Normally what we're going to be using it for CHF is we're going to be dosing a little bit higher, say 5 to 10 mics per kilo per minute. And when you give an infusion like that, you end up seeing more beta-1 effects. So this gets a very similar activity to what you would see with dobutamine, right? It's going to be good because it'll help to get the heart rate up, it'll help get the contractility up, it'll help with cardiac output. When you get higher doses than that, we end up having what you call vasopressor effects. What does that mean? Vasopressor. If I'm pressing on your vessels, what's your blood pressure going to do? It's going to go up, right? So at that point there, now it's working as a vasopressor to actually cause it'll cause some beta-1 activation, right? But you're also going to find what else? If it activates beta-1 receptors, ostensibly what else could it activate? Alpha receptors as well. So it actually will activate alpha-1 receptors as well, right? No line there. So when you get those higher doses, it's good because it will stimulate the heart, but it also will help to clamp down on the vessels there and actually increase your heart, your blood pressure. So again, depending on the dose you're administering, that's how dopamine's a little bit different there. Okay, kind of make sense? So it's a dose-dependent effect. Now, I'm not going to have you memorize those specific dosing intervals, but I was going to say, you know, if I ask a test question and I say a patient is in acute decompensated heart failure, you know, they have low blood pressure, they're not really perfusing, what might be a good option for them? Well, dopamine might be a good one, especially at those higher doses. You'd be able to see those pressure effects along with the cardiac output effects. Make sense? I hope so. Any questions on that? If not, let's roll into the next section. I know some of you almost had that spike of dopamine. You're like, wait, are we done? And then I said, no. No, we're not. I already have it up, I think. All right, so let's get into part 4 of this, which is posted, right? You guys see it? I hope so. You don't see it? Okay. It's not a very funny joke. Okay, so let's talk about our antiarrhythmics. So why do we have arrhythmias? What are some causes for that?
Electrolyte imbalance.
Electrolyte imbalance is a big one. What else? You can have ectopic foci. You can have, what else? You could have things like toxins can do it, right? What if someone overdosed on their diltiazem? Could that cause an arrhythmia? For sure it could, right? You could have other things like ischemia can do this, right? There's a lot of reasons why someone might be having an arrhythmia, and so it's important that if you can, identify and remove any of those precipitating factors. So if their potassium's too high, anyone know how to get rid of potassium? We could use dialysis. You could actually use an artificial kidney and pull that off potentially, right? If they have low potassium, they're having an arrhythmia, what do? Give them IV calcium, right? Glad no one said eat a big banana. That'd be a lot of banana you have to eat in order to get enough mill equivalents of potassium. But you get the point, right? So again, you got to fix the precipitating factor here. And so a lot of times you're going to find that the issue may either be an acute problem, which you can fix acutely, right? So if it's an electrolyte imbalance, you can fix the electrolytes. However, some people are just going to be more prone to that, maybe due to ischemic issues. They could be more things that are irreversible, in which case you need to figure out what you want to do with the patient, right? You know, if it's an ectopic foci, maybe you want to do an ablation, right? However, if it's due to ischemia, maybe you need to have something more of a chronic sort of therapy for these patients here. And so do we want to terminate the arrhythmia? Do we want to prevent the arrhythmia from coming up? Do we just want to control heart rate? Do we just want, what do we want to do? And so we're going to focus on the different types of therapies there. And one of the big problems you're going to run into with antiarrhythmics is, guess what's a common side effect, or not common, but a serious side effect of every single antiarrhythmic? And cause arrhythmia, right? Just like any anti-seizure meds we give, guess what they can cause? Seizures, right? So that's one of the big things we're going to be focusing on. So it's important to know the mechanisms, to know what the underlying arrhythmia is, and see how the drugs are going to be interacting with that, right? And again, you can kind of think about electrophysiology as a moving target, and so depending on, you know, what kind of ischemia they've had, depending on what their electrolytes are doing, that, you know, the focus can change from day to day potentially. So how we classify our drugs is going to be based on their mechanism of action. Some of these are going to be repeats, some of these are going to be new drugs, as we'll see. So for instance here, class 1 are going to be things that are going to be blocking sodium channels. Okay, and we'll look at the action potential here in just a moment to kind of get a refresh on that. We're going to see some things will work on blocking potassium channels, how that's going to have an effect on repolarization. And then also it's kind of nice to do the class that we've already talked about quite a bit. It's going to be our beta receptor blockade and our calcium channel blockers. We'll see how they're going to be fitting into the picture here, okay? And so here are the different classes we're going to get into. So class 1 is going to be broken up into class 1B, 1A, 1B, and 1C. So I have to know those kind of delineations there, and these are mainly going to be sodium channel blockers. We'll talk about our beta blockers as class 2. Talk about class 3 being our ones that are blocking repolarization of the cells by blocking potassium channels, and then we'll have our calcium channel blockers as class 4, and they'll have kind of a hodgepodge of miscellaneous ones right at the end there, okay? What I'm going to want you to know is what type of arrhythmias these drugs might be good for. I'm not going to get like super in the weeds on that kind of stuff. I'm not going to say it's good for a paroxysmal atrial tachycardia with block. I'm not going to get that in the weeds. I may say, like, is this one going to be good for like an atrial arrhythmia? Is it good for a ventricular arrhythmia? Because that delineation is going to be important to picking what kind of drug you want to use. Some are good for both. Some are really only good for atrial arrhythmias. Some are better just for ischemic arrhythmias due to ischemic tissue, right? We'll look at some cases of that. Get to know side effects. How to manage those side effects, right? And any drug interactions are going to be coming up here, okay? So pretty much the same we've already talked about. So I don't know why I hear all this flurry of typing. It's stuff you got to know anyway, right? Anyway, don't get scared by this slide. I just want to give you an example of the different kind of arrhythmias that could be treated with these different classes of drugs here. In broad strokes, what you're going to find is that class 1 and class 3 are going to be good for both atrial and ventricular arrhythmias, because they're going to have more broad activity. They can work kind of on both. Class 2 and class 4 are mainly going to be better for atrial arrhythmias, or arrhythmias of atrial origin. And a lot of that has to do with conducting through the SAAV node down to the ventricles, right? So what effects they have on the nodal tissue versus what effects they have kind of globally on the rest of the tissue. And that'll make more sense when we talk about that specifically, okay? So looking at sodium channels, why are sodium channels important for cardiac function? They trigger off that action potential, right? Remember phase 0 of the action potential? What's coming in? Sodium. You guys have covered this before, right? At least once, maybe twice, maybe 3 times. 3 times the heartbeat. That 3 or 4? Okay, we're going to get it again here, so maybe 4 or 5 now. Anyway, so sodium incoming is going to be important. So normally when the action potential comes along and is triggering off, again, this is not in the nodal tissue, this is in just a regular old myocyte, so those fast response cells they talk about. The sodium channels are important for that phase 0 depolarization here. That's what's causing most of the actual contraction of the muscle, or leading to that contraction. And so normally what you're going to find is that the sodium channels will either rest in a resting state, where kind of nothing's happening. There's the activated state once they've actually been triggered by an oncoming action potential to open up, and they allow what to come in? Sodium, right? Makes sense. It goes along or against the concentration gradient. Along the concentration gradient. Once those open up, sodium's in a much higher concentration on the outside of the cell. It's going to come right in. What's a normal sodium? 135 to 145. It's much less of that inside the cell, so it's going to flood in. That's going to cause that initial depolarization, right? And then it will have an inactivated state. Now, why is this inactivated state important? It establishes the what period? The refractory period, right? Because as soon as you have a myocyte trigger off, do you want it to be able to trigger off again immediately? No, because everything has to be very well orchestrated here to kind of work in tandem with one another. And so if you have these cells kind of firing off immediately afterwards, it's going to cause an arrhythmia. So this is why the refractory period is really important here, to make sure you don't have these sodium channels opening up prematurely and causing another contraction to happen, okay? Make sense so far? So by looking at our different antiarrhythmics, specifically class 1, you're going to find they're going to be working on different states of the sodium channel in order to prolong this effect, right? Because if I block the sodium channel, what do you think it's going to do to the rate of depolarization in the cell? Speed it up or slow it down? I'm blocking sodium channels, slow it down, right? Because less sodium is going to be able to get in. Make sense? And you can kind of see that, right? If you're looking at, say, a ventricular cell here, you can see that by blocking sodium channels, you're going to find that the solid black line is a normal, and then the dotted, the dashed line is going to be what the effect would be from the medication here. And so you can see that you're going to find that the rate and the extent of the depolarization is going to be less than what it would be normally, okay? So the sodium channel blocker is going to slow this process down. It's also going to go ahead and decrease the actual total height of that can reach there, because less sodium is getting in overall. So class 1A antiarrhythmics are going to be slowing down phase 0 of depolarization. It's going to slow down the conduction, and it's going to prolong the action potential. So what sort of intervals on the EKG do you think you might see extended when you do this? So QT, but more specifically, it's going to be that ventricular depolarization. QRS. So you actually will find that the QRS will actually extend out when you give a sodium channel blocker. Okay? So you can kind of get a feel for what these kind of changes are going to occur within the action potential when you introduce these kind of medications here. Okay? Now, again, I'm not going to get so in the weeds in terms of talking about, well, does it affect the open versus the inactivated channel more so or not, or how fast does it dissociate, but again, it is good to know the different classifications here. So if you have a patient who's on, say, taking quinidine or disopyramide, you're going to be able to know that, hey, that's a class 1A antiarrhythmic. And you're going to know that pretty soon here, because I'm about to tell you about them. Anyway, so the thing I remember for my class 1A antiarrhythmics is I remember PDQ. PDQ normally stands for? It used to, now it does now, but it used to stand for pretty darn quick. So if you had an arrhythmia, you want to treat that pretty darn quick. I don't know, that's how I just thought about it, right? What does it actually stand for? People... That's a chicken place. Isn't that Tim Tebow's restaurant or something? Yeah, something like that. People dedicated quality. You can think about that if you want, whatever. But class 1A antiarrhythmics are also PDQ. So it stands for procainamide, disopyramide, and quinidine. Those are going to be the 3 we're going to talk about. So quinidine is going to be this first one here. So again, working to slow that conduction, prolong the refractory period. Now, when I get into the specifics between the drugs here, they all have the same activities within class 1A, but the side effects may differ a bit from one drug to the other, as we're going to see here. Other things you can see in terms of indirect actions of quinidine is actually some anticholinergic effects, which can affect heart rate as well. Normally, anticholinergic effects do what to heart rate? Slow it down or speed it up? Because normally, acetylcholine acts on muscarinic receptors on the heart to slow it down. By blocking that, you can speed up the heart, right? So again, that could be something you may see. You might see tachycardia associated with this potentially. And then at high doses, it can actually cause alpha blockade, which would do what? Hypotension, right? Because you're blocking alpha receptors, you're relaxing those vessels there. Remember when I did that talk at the end of pharmacodynamics, we were just talking about autonomic stuff? Yeah, well, most of you probably repressed that memory, but I'm going to try to bring it back out of you, right? We're going to relive that trauma so that way we can incorporate it back when we were asking about these questions. Got to know this autonomic stuff because, again, so many medications are going to be affecting this, right? So what can we do with this, right? What can we do with quinidine? Well, it's going to be good for both either atrial or ventricular, arrhythmias, as you can say. I'm getting towards the end of the day, so my words are going to start to spill out after a while. But anyway, they can either be used to maintain rhythm, say with something like AFib or A-flutter, and they can also help to control. So when we talk about rate control versus rhythm control, have you guys talked about that concept yet? So when I say rate control, what do you think that means? Some drugs are going to be good at just controlling the heart rate. So for instance, if I have AFib and I'm worried about that fast atrial rate being transmitted down to the ventricles, you know, because again, the atrial, even if the atria is not really working all that tip-top shape, like as long as the ventricles are doing their thing, you can still function, right? You can still perfuse pretty well. By using what we call rate control and controlling how fast those conductions are going down into the ventricles, you can maintain normal heart function, okay? Let's go rate control. Rhythm control is where you actually terminate that arrhythmia and you reestablish normal electro action, right? Electrophysiologic action, okay? So it's the difference between rate control and rhythm control. We'll talk about the difference between those when we get to like beta blockers and calcium channel blockers in a minute, but they maintain the rhythm, right? Without it, maybe you go back into AFib, but it can maintain that rhythm. So this is a form of rhythm control. In some cases, you may even use it to convert patients from, say, an atrial arrhythmia back into normal sinus rhythm. Don't use it quite as often, but why do you think you would need anticoagulants on board when converting someone? Because when you have those atria that are just sitting there just kind of quivering, what happens to that blood there? It can pool, it can coagulate, and then you can get what would develop from that gets dislodged. PE or stroke? Stroke, right? Because it's on the left side, so it's going to exit out the left side of the heart. It's going to go back to the brain first. So that's why we worry about anticoagulating these patients there, right? So you either have to be on heparin or something in order to prevent that stroke from occurring there. So again, not done super commonly. We'll talk about some drugs you can do that more with. This is what we get into when we talk about cardioversion, right? For converting someone from an arrhythmia back into normal sinus rhythm. There's what we call chemical cardioversion. This would be an example of that, but there's also what else? Electrical cardioversion, where you just shock the patient back into a normal rhythm, okay? Which one do you think I'm a bigger fan of? Chemical, of course, right? If you can do it with drugs, let's do it with drugs, right? Don't take that out of context. Other things to be considered of is some drug interactions here. This will affect CYP2D6. CYP2D6 is going to be important for drugs like codeine or morphine, can actually affect them. And by inhibiting that, what do you think would happen to the effects of morphine? They'd be stronger, they'd be sticking around for longer. Opioids, what kind of side effects do you think about with like morphine? Sedation's a big one, right? One to think about more chronically, but certainly constipation could be worsened by that, euphoria, things like that. So those interactions are important to consider. Now, notice this is the D-isomer of quinine. Anyone know where you find quinine? Ah, tonic water. Where would you find that at? So you're going out to the clubs, you're doing your thing. Notice they have black lights in the club. What happens to your gin and tonic? It actually fluoresces, right? So actually this is an isomer of that. So if you ever wondered why tonic water, don't take that hate. Just it's okay. They don't know. They're not refined enough for that. But so yeah, so if you ever have like a gin and tonic, it's under black light, actually fluoresces, and it's due to that quinine that's in there. So this is actually an enantiomer of that. So again, another useless fact you can wow your friends with. Okay. Anywho, so what's interesting though, that actually comes from, it's actually a plant-based product, actually comes from a certain tree here, and it causes a very particular, sort of constellation of signs and symptoms that can develop when you have levels that are too high. This is called synchonism. This is something that's unique to quinidine. I guess presumably if you got too many gin and tonics, maybe you could develop this too, but it's not common. But quinidine certainly can cause this, and so basically what it can develop is you have this dizziness, this blurred vision. Why would you have blurred vision from this drug? Remember, said anticholinergic effects. Remember, blind as a bat. right? And you also get this tinnitus associated with it as well. So if you ever have that like patient, maybe a board style question, when say patient presents, a history of AFib, and they present with, tinnitus, dizziness, and blurred vision, it's quinidine toxicity, right? It's that synchronism is what that's called. But anyway, so you're going to see that hypotension can develop to the alpha blockade. Arrhythmias obviously going to be a potential problem there with these drugs. And then interestingly enough, you can also see things like torsades, right? Torsades is typically caused by what kind of interval prolongation on the EKG? QT. Yeah, so QT would be prolonged, QTC specifically would be prolonged, and so that could lead to torsades, because remember, you're slowing down the action potential, so the QRS will be elongated, but also as a result of that, QT gets elongated as well, right? And so that's when you see that sudden death. That sudden death is related to usually a ventricular arrhythmia the patient goes into, and they may not be able to be resuscitated unless that drug, effect goes away potentially. So just something to think about. Okay, so procainamide is going to be actually a derivative of procaine. Anyone know what procaine sounds like? Sounds like cocaine or lidocaine or tetra. So it's an anesthetic, right? Actually, if you look back at our anesthetics and how they work, they block sodium channels. So it makes sense that you could use an anesthetic as an antiarrhythmic, and that'll actually make sense because we're going to talk about lidocaine just a little bit, right? So we'll talk about procaine and procaine accessories. Anyone? Nothing? No King of the Hill fans? All right, Sean's got me. That's all good. Anywho, so procainamide is another one in this class 1A set of antiarrhythmics. It's again blocking the same sodium channels that you'd see with quinidine, no difference in there. However, you will find that it has a little bit difference in terms of the side effects, right? Side effect profiles will be a little different with this one. This drug is also undergoes acetylation for its metabolism. What other drug do we talk about with acetylation? It's on the last test.
Yeah, got it right.
Causes a rash, a butterfly rash. Looks like lupus.
Yeah, got that part.
Hydralazine was the drug.
Oh,
Hydralazine was another drug that also was undergoes acetylation. This is going to be in that same sort of category in terms of metabolism there. So if you have a slow acetylator, guess what also can happen here? Butterfly-like rash, right? And actually, procainamide is actually more likely to cause it than hydralazine is. If you give it if you actually look at the incidence of it, more patients who are on this are going to get it than those with hydralazine. So again, those are some of the concerns you're going to see with that. Again, the slow acetylator, more likely to see toxicity, including arrhythmias, including that rash, etc. Right? Again, very similar effects. Again, 20 to 50% of those patients in the slow acetylators are going to be developing that lupus-like syndrome there. So it may be a reason for discontinuation to switch over to something else potentially. And we'll use this occasionally for IV for sometimes if we have the need to cardiovert someone. It's rare that we do this, but every once in a while we use procainamide. Some of our congenital heart kids that have undergone open heart surgery sometimes require this to help control their arrhythmias. Just depends on the case there. Okay. And then disopyramide is going to be the third one of the class 1A antiarrhythmics, right? So this is the PDQ, this is the D part of that, disopyramide. Very similar effects to quinidine. Also may have some negative inotropic effects, maybe not great for patients, maybe you have like AFib and also CHF along with that. Again, very similar in terms of the indications here, either atrial or ventricular arrhythmias are fine for this one. And then very similar sort of side effects, nothing as unique as what you would see with either procainamide or with quinidine, right? So remember, quinidine's got that synchronism. Remember, procainamide undergoes acetylation, so you can see a lupus-like syndrome. This one doesn't really have anything super unique to it, okay? That makes sense so far?
Yes.
Everyone with me?
Maybe.
Maybe. That's okay. We'll find out in a couple weeks. Anywho, so now we're into the class 1B antiarrhythmics. How much time do I have? I have 9 minutes. That's perfect. So the 1B antiarrhythmics are going to work a little bit differently, basically because they actually have the ability to work on these ectopic foci, right? And what are those? It's like a piece of tissue that's kind of firing off abnormally, right? So that is typically caused by what? Ischemia can be a big one, right? So like maybe you've had a patient who's having infarction and say in part of the ventricle, and that is leading to an arrhythmia due to that. As part of that ectopic foci you can see there. And so this one actually is going to work better in those tissues than in the other surrounding tissue, right? So this actually might be good to work in patients who have had MI recently, right? Or they're in a ventricular arrhythmia due to MI. This is actually a good case for utilizing one of the 1B antiarrhythmics there. So that's kind of its use case as opposed to say like the 1As, which didn't really have that effect. So lidocaine is going to be the big one in this case. We mentioned lidocaine. You normally use as what?
anesthetic.
And use it as a local anesthetic, right? Locally working to numb up, nerves and things like that. So if we had to suture up a laceration, or if you're having some kind of like herpetic neuralgias, you can use it for lots of different things. But used IV, it works as an antiarrhythmic because it's blocking the same sodium channels on the nerves as it does the heart, right? So it kind of makes sense. You can use it for a couple of different indications here. So as I mentioned, acute MI tends to be one of the more common ones I see. You're actually seeing lidocaine kind of going by the wayside a little bit in favor for one of the other antiarrhythmics we'll talk about later, but you'll still see it used occasionally. Things like Wolff-Parkinson-White's another one you might see it done used for. However, remember that if I was, say, giving a lot of lidocaine, say, peripherally for a laceration, a large laceration I was trying to suture up and I wanted to numb that area there, what side effect do you think you could see from that? Well, if I got too much lidocaine being absorbed peripherally, it gets into the central circulation, it could cause an arrhythmia, right? Because all these antiarrhythmics can cause arrhythmias themselves. So that's another toxicity you want to think about with lidocaine and those cases there. One unique thing with lidocaine is important to know that patients with CHF who have kind of impaired blood flow to the liver due to congestion, they're not going to be able to metabolize this drug as well, right? Or if they have poor liver function, they're not going to be able to get the drug to the liver and actually metabolize it as quickly. And so in some cases, you actually have to give like half the normal dose for those patients just to make sure they don't accumulate too much, because not only can blocking those sodium channels cause arrhythmia, but what do you think it does in the brain? Just like by blocking sodium channels can cause an arrhythmia in the heart, can cause kind of the equivalent arrhythmia in the brain, which is a seizure. Yeah, so seizure is another toxicity to think about with that. Normally patients will complain about like a metallic taste in their mouth, and that is usually indicative of there's something, we got too much lidocaine on board, we need to do something about this. So one thing to think about with that one. As I mentioned, the CNS toxicity is the other big thing you're going to be watching out for. So nystagmus can also be another one kind of early on. When I say nystagmus, what does that mean? Abnormal eye movements there, right? So in that case, you would go ahead and if you saw that, you would say, okay, let's back down off this dose here. And other than that, it's going to be again using those kind of sparing use cases, especially in those cases of MI, lidocaine, it can be a pretty useful drug. Okay. So any other questions so far? So you can see the difference in activity a little bit between the 1As and the 1Bs. I don't know if I have enough time to cover all the 1Cs and answer any questions, so I'll stop here, okay? Let me check the board real quick. What would be considered weird dreams? I don't know. This is the appropriate place to talk about that. It's very subjective, as you might know. They're usually quite vivid, though, is usually what you kind of I hear described for certain drugs. So, like we talk about pulmonology, we get to talking about Chantix, which is used for smoking cessation. That one is associated with extremely vivid dreams. I've had some family members who are trying to get off of tobacco, and they talked about they just thought everything was super real, and they woke up and they were just like, that was the scariest thing I've ever been through in my entire life. I'm going off the drug entirely. So it depends on the patient. Some people may find it pleasant. Most patients tend to find it pretty kind of weirds them out a little bit. What other questions can I answer for you? If nothing else, then I guess I'll let you go, and I'll see you on Friday. I think we have class on Friday. I'm not with the test on Friday. I think we have pharm in the afternoon as well, right? Okay, so I'll at least see you there for that. I won't be here for the test specifically, but certainly I'll be here tomorrow. So if you have questions regarding EpiBio, I would suggest coming by, talking to me, or writing me an email or anything like that, okay? Okay, I'll see you guys next time.